Good morning. Welcome to Common Part B, Infectious Disease, Rejections and Denials. My name is Mary Mucko. I am a member of the WPS, Provider Outreach and Education team, and I will be your host today. I'm joined by my teammate, Bailey Lawson, who will assist with some behind-the-scenes help. This webinar today is for those people who are wishing to learn more about the most common reasons that WPS rejects and denies claims, Part B claims that is, for infectious disease specialty. You might be asking why we're offering this topic for education. It is a requirement of CMS's that the MACs provide this education to prevent future claim rejections and denials. And just as advertised, the information that I'm presenting in this webinar today is based on actual Part B claims data. The presentation is available for download from our live events webpage. The page address is being placed into the chat. You can take time to download this now if you've not already done so. We will record this session, and barring technical issues, we will post the recording to our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, and it will remain there as long as the information remains current or we otherwise determine that we need to remove it. Now, if you have questions, please place them into the chat. I will answer questions as time permits. But if I don't get to your question, I will email the answer to you after the webinar. I'll make that email either directly to the learner that posed the question, or I'll compile a list of questions and answers and send it out to all of you who are participating today. Now, if you have a claim-specific question, I am unable to provide an answer, and the reason for this is that Provider Outreach and Education team specialists have no access to claims history, so we can't go into the claims processing system and see what happened to your claim, but customer service can. You can contact customer service with any provider-specific or claim-specific questions, and they'll be able to access claim details in the claim processing system and help you with your question. We include a disclaimer in all our live events. This presentation is for education purposes only, and I made every effort to make certain the information I'm about to provide is current and accurate, but the information is subject to change. It is on the CMS website that you will find the Medicare rules that determine final coverage, and this will always prevail. CMS does prohibit recording of this presentation for profit-making purposes, and because we don't know how someone might use a recording, we simply ask that you not record it at all. This would include any screenshots. We will create an encore of the presentation, just as I mentioned a couple of minutes ago, and you can use that for future reference. Based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I have included this CPT copyright notice in my presentation materials. Your continued participation in this event today infers that you agree to the terms of this copyright notice. Here is the agenda for today's webinar, and it should look very familiar to you. This is exactly what the advertisement stated. Today, my goal is to share with you those most common reasons for rejections and denials for infectious disease Part B claims. Now, this is not a deep dive into policy and coverage, but it's simply a look at the most common reasons for Specialty 44 rejections and denials based on actual claims data. I plan to define rejections and denials and talk about the difference. I'll reveal the reasons for rejections and denials based on the data that I pulled and analyzed. I'll discuss ways to fix and avoid these, and I'll provide you with many resources. Now, that's a lot of information to share in 60 minutes. I'll be moving quickly through the slide deck, and I may also ask you to review some of the information following this live presentation. That information is mostly those helpful resources that are included at the end of this presentation, at the end of the presentation materials. Now, if you have questions, you can place them into the chat, and I'll tell you later how you'll be able to send them following this event. Now, in order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process. Based on a law that requires it, most providers submit claims electronically. When submitting claims to WPS, there are reports that generate to confirm your claim receipt and report more specific information about data requirements. And one of these reports is the 276-277 report. The Medicare 276-277 Companion Guide was prepared by our Electronic Data Interchange, or EDI staff, and that helps submitters understand the claim requirements and know when they need to correct or resubmit the claim because it didn't make it into the door, so to say. We call those pre-pass edits. Now, claims that do move past the pre-pass edits and get in the door, if you will generate a remittance advice. Some people call this the notice, some people call it simply the RA or the remit. There are two formats, the electronic remittance advice, or the ERA, and the standard paper remittance, and with few exceptions, most providers receive that electronic remittance advice. Now, the RA provides very important information to the provider about what happened during claims processing, whether the claim was rejected, whether it was actually adjudicated. If it was actually adjudicated, you'll find even more information on the remittance advice about adjustments to the claim, denials, those items listed here on the right side, missing items, refunds, and even sometimes offset information. Now, when you're looking at a remit, you will find various reason and remark codes. These are typically in an alphanumeric format. When claims paid differently than billed, a claim adjustment reason code will appear on the remittance advice. Sometimes a remittance advice remark code will also appear. The remittance advice remark codes, or RARCs, actually expand on details that are described by a reason code, and they do so to provide more details about the adjustment to the claim. Another type of code that you'll find on that remittance advice is a group code, and group codes actually assign financial liability for any unpaid balance on that claim. A CO group code stands for contractual obligation, and this means that the provider is liable. You can't bill the patient. A PR group code on the remit means the patient is financially responsible. Now, we hear a lot of comments about these reason and remark codes. It's not uncommon that a provider who's speaking with one of our customer service agents might say, these are really too cryptic, or that they contain outdated acronyms. While we'd really like to help, it is another contractor, not WPS, who maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on their website where you can find contact information also, should you wish to suggest a change to the code lists, including those sometimes cryptic code explanations. This slide is inserted in the presentation materials, and I'm covering it today to show you a comparison of a rejected claim to a denied claim. On the left side, I've included information about rejected claims. CMS calls rejected claims unprocessable. They're returned on the front end because they are unprocessable. The reason we can't process that claim or adjudicate that claim actually is because something's illogical, something's missing, or there's incorrect information on that claim. The claim form instructions that CMS has published tells you what you need to put where on a claim and when you need to include it on the claim, whether it's required or whether it's just situational. Because a rejected claim is not processable, it's an unprocessable claim, there are no appeal rights. What you need to do is resubmit the service. Fix it and resubmit it. Now on the RA, a notification to you, or a flag that should raise every time you see an MA130 and a CO16, is that you need to fix and resubmit it, because those codes on the remittance advice tell you that this claim or claim line is unprocessable and the patient's not liable. You can't bill the patient. For a denied claim, on the other hand, we actually have adjudicated the claim and something was denied, either the entire claim or a claim line, because it fails to meet Medicare's payment criteria. Now, this could be due to a law or what we call a statutory requirement. It could be because Medicare deemed that those services, based on what was reported on the claim, are not medically necessary. And this would include any frequency edits or any utilization parameters. There's also a good deal of claims that are denied due to eligibility. It could be that the beneficiary wasn't eligible to receive services on a particular day under Medicare or based on their Medicare enrollment, or that the provider was not eligible on the day that the service was provided. These are just three of multiple reasons why we may deny your claim. And what to look for on the remittance advice, besides those reason or remark codes, is the MA01 code. That code, when showing up on a remittance advice, provides appeal rights. And with very few exceptions, you mostly have appeal rights on all denials at Medicare. There are just a couple of exceptions. And of course, when we deny a claim, the patient liability for the services or the costs is determined. During the next slides, I'm going to discuss whether you need to correct or appeal the claim. There are different actions that you can consider taking, but you do need to review that remittance advice and you need to choose the action you need to take. For an unprocessable or rejected claim, you're going to need to fix the error and resubmit that claim to Medicare. If the claim or claim line denied, there may be multiple actions that you can choose from, and I've listed them here on this slide. You might use the clerical error reopening process to fix a clerical error, and CMS defines these rather as human or mechanical errors on the part of the provider or the contractor. This would include minor errors or omissions. Another action to consider is an appeal. The remittance advice will provide appeal rights when they are available, and I'll discuss appeals in a little bit more detail in just a couple of minutes. Registered users of the SecureNet Access Portal, or SNAP, can render or request a clerical error reopening or render an appeal by using this self-service tool. And this is just one of many self-service tools that we offer, and these really do offer the most efficiencies. We do have a portal user manual that provides illustrations and step-by-step instructions on how to use these portal features, these and other portal features. And I want to show you just real quick here where you can find that. We do get a lot of questions about our SecureNet Access Portal and how to use it. In addition to some great YouTube videos that we have available on our YouTube channel, we also have that portal user manual. When you're using when you're on the WPS website, and all of the links are embedded in your presentation materials to these resources, but Bailey's also placing some of them into the chat for you. But when you are on the WPS homepage, and this is our homepage here, you can look under or in this big blue box at the top. This is where registered users of SNAP can log in to use SNAP, the SecureNet Access Portal. But right here under the login button is a link to that portal user manual. It has illustrations, who doesn't love pictures, right? And step-by-step instructions on how to use all of the functionalities of SNAP, in addition, or for example, that clerical error reopening process. In addition, you can scroll to the bottom of any web page, not just our home page, and in the big blue box at the bottom under the Educational Opportunities heading, you will see a link to the portal user manual. Okay, so just a really quick way to get to that important information so you know how to use the functionalities of SNAP. I do want to talk just a little bit about appeals. I didn't advertise I'm talking about this, but it really goes hand in hand with those denials and what you need to do. So you need to know how to request an appeal if that is the action you choose. For claim denials, most often you can request an appeal, and the purpose of the appeals process is to ensure the correct adjudication of claims. Now, physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by MACs. Now, the beneficiary or their representative can request an appeal on any service processed for them. Providers and suppliers, though, are limited. They may appeal services for which they accepted assignment. And for unassigned claims, they can act as the beneficiary's representative, but only if that beneficiary signs an authorization statement to do so. In addition, if it's a non-assigned claim, providers and suppliers can request a redetermination if Medicare denied the services as not reasonable and necessary, or in those cases where that provider or supplier billed in excess of the limiting charge. And of course, when billing in excess of the limiting charge, if any monies were collected from the patient or the beneficiary, they would need to make that refund as well. The first level of appeal is the redetermination, and that is the only appeal level that is rendered at the Medicare Administrative Contractor. So that's the only level of appeal our staff at WPS renders. Time frames apply to each level when submitting an appeal. Additionally, there's a minimum amount in controversy that applies to level 3 and level 5. And in order to reach that dollar threshold, that minimum amount in controversy, you can combine similar denials or like denials on more than one claim or for more than one patient in order to reach that amount in controversy. Now, I did mention that there were 5 levels. We have some great resources on our website. We have videos on our YouTube channel that really go into detail about appeals, but I didn't advertise I'm doing that today. But I do want to share with you some really helpful resources. The first one here on this slide is How to Appeal a Claim Determination. That is a resource on our website. It tells you step by step what you need to do. It tells you all 5 levels, tells you where you need to send it, and so on and so forth. The second bullet is one of my favorite appeals resources, my go-to, so I want to share it with you. It's the fee-for-service appeals process flowchart. You can see the graphic on the slide, but I do want to open it and speak from it to talk about it a little bit. This flowchart shows you, here it's coming slowly, and I'm going to drag this over and make it bigger so you can see it. All right. This shows you the standard process and expedited appeals process. Expedited process applies only to some Part A claims. I'm only talking about Part B claims, so I'm following along the left side of this flow chart. For original Medicare, Parts A and B fee-for-service. Of course, you have your initial determination. This is when your claim is processed. You have 120 days to file a first-level appeal, which is a redetermination rendered by the MAC. The MAC has 60 days to render their decision and send you notice. If you disagree or do not agree with the decision by the MAC, that redetermination notice comes to you. If you don't agree, you have 180 days to file the next level, the second appeal level, reconsideration, which is done or performed, rendered by the qualified independent contractor. We call them the QUIC. They have 60 days then to send you notification of their decision. As you can see, we move on here to the 3rd level of appeal, 4th level of appeal, and the 5th and final level of appeal. 3rd level is Office of Medicare Hearings and Appeals. We sometimes refer to that as the ALJ hearing. Again, you have your time frames that you need to follow. This shows you inside the box that this contractor has, or this ALJ has 90 days to notify you of the decision. You have 60 days to file the next one, so on and so forth. Medicare Appeals Council is the 4th level of appeal, and Federal District Court is the 5th. You'll notice that the time limit from is missing from that box because there is no specified time limit for Federal District Court to render a decision on your request for appeal. You know, there's a lot of things that come into factor. One of them being, of course, their court schedule. I did mention to you that there's amounts in controversy for level 3 and level 5. Those show here on this flow chart, another reason why it's one of my favorites. The amount in controversy for level 3 in 2025 is greater than or equal to $190. And for Federal District Court, that AIC amount is greater than or equal to $1,900. How do I know that this is 2025 information? Scroll to the bottom and it tells you right here on the bottom that this chart reflects the amounts for calendar year 2025. So, you know, come January, make certain that you're looking at only CMS's updated information, because that amount in controversy usually changes each calendar year. Not always, but usually. All right, let's move on now to the data dashboard. The next portion of my presentation is that one that focuses on the data. I used a tool that we call the data dashboard, the claims dashboard, to pull the data that I plan to share with you today. That dashboard is an interactive tool that is designed by our data informatics team. The name of that department is what we call Insight here at WPS. Among other things, they mine data. They're looking at data trends. They're assisting. What I want to say here, they are assisting medical review with the data that they need to determine what edits to turn on and off, and so on and so forth. So we do have a data dashboard, and just with a click of the mouse, you can move around and change what you want to look for on that dashboard. And I am going to show you quickly. I'm trying to pull it open here, and I'll slide it over in just a minute. There's different ways to view the data. We can, in an instant, click of the mouse, review rejections or denials. We can drill down by state. We can even drill down to county. We can look at rejections or denials by the reason. Why did it reject? Why did it denial? Which codes rejected? We can request specialties. Today's data is specialty 44 claims, infectious disease. We can also look at trending. So I pulled open the claims denials dashboard, and I do want to show it to you quickly here. This is the information or the tool, the dashboard that I use to pull information today. So I can look at claims in all of our jurisdictions. I could choose to look at Part A or Part B or both. I can look at denied claims. I can look at unprocessable claims if I want. Just in the just by typing in those variables or those data slicers, I'm just gonna. Oh, it doesn't want. Here we go. I'm going to go back and choose denied. It's already populated there. I can change this specialty type and just look how quickly I can find. Oh, the reason why there's no results is because there's a code out here. So I can go out and say I want to look at specialty 44 claims. I can choose to look at claims only in the state of Iowa. Let's just pick Iowa. Just that quickly. I can search for a particular code. Just that Of course, that happens. Whenever anybody is watching you type, why can't you type what you're trying to type, right? You know, I can ask for a particular code. So just like that, we can look at, we could choose the data slicers to look at specifics. So today's webinar is designed to give you information about rejections and denials for specialty 44. Now, some of you might be saying, what is she talking about? What does she mean by specialty 44? Well, specialty codes are two-digit codes that are assigned during the enrollment process. When you enroll with Part B, you self-designate. Most providers, not all providers, will self-designate their primary specialty. And it is that primary specialty code, that two-digit code, that's used in that computer logic and in our edit system during initial claims processing. Okay, so these are these two-digit specialty codes. Sometimes providers contact provider enrollment, or they use the provider enrollment chain and ownership system known as PAYCOs to change their primary specialty. Sometimes that occurs. So it's that two-digit code that means infectious disease provider. It's a 44 specialty. The dates that I looked at were April 1 of 2025 through June 30th. I'm going to pull that data dashboard back over here and show you that currently the data that's showing on the dashboard is June 1 of 2025 through August 31 of 2025. The data was last refreshed on 9/11, so they just did a refresh. But the data that I'm presenting now, because I had to prepare these materials, was last refreshed on July 14th of this year. So let's take a look at the most common reasons for rejections for infectious disease Part B claims at WPS. I have included the number of claim lines rejected or denied in these slides. So the number one reason claims submitted by infectious disease providers rejected, not denied, is because the rendering physician number on that claim was invalid or missing, 427. The second reason, to the top reason, claims must be submitted to the Railroad Retirement Board contractor. What this rejection means, 337 of them, is that this claim or the claim was submitted to WPS when it should have been submitted to the railroad board specialty contractor. How do you know that a patient's claim should go to the railroad board contractor and not WPS? You would need to check your eligibility. Also, if you or your staff at your business, your entity, your clinic, whatever, looks at that Medicare card that the patient shows or that they present when they come in, it will tell you right across the bottom of the card that it's a Railroad Retirement Board beneficiary. Railroad retirees with Medicare Part B, their claims are submitted to and processed by Palmetto GBA, not by WPS. So 337 rejected claims because it came to us and should not have. 277 rejections during that 3-month period occurred for Specialty 44 because there was an incomplete or invalid plan information for other insurance. So in other words, you told us on the claim, yes, there's other insurance, but you neglected to or didn't, or it was just missed. We understand it happens. The information was either invalid, it was entered and it's invalid, or it was incomplete. Remember, the claims processing instructions tell you you need to fill out item number 1. You need to fill out number 2. Number 3, you need to fill out. I'm just using some examples here, but maybe item number 17 is situational. You don't have to fill it out, but if you do fill it out, it needs to be valid in a correct format and so on and so forth. So just giving you some examples here. Number 4, claim must be submitted to another contractor. Well, that could be another MAC. Maybe the claim shouldn't be processed by WPS. We are jurisdiction 5 and jurisdiction 8, Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. Patient, insured, ICN, and name do not match. 65 rejections. Okay? The name of the patient needs to match exactly with the name that's on the Medicare beneficiary's Medicare card. If there's a middle initial, you need to have that middle initial on the claim. Missing, incomplete, invalid, name, strength, or dosage of drug. For this one, a drug was billed, but you failed to let us know the name, strength, or dosage of the drug. Now, that would be one of those situational pieces of information. If you're billing for a drug, then you need to include this information on the claim. Typically, if it's policy driven, it will tell you how to do that in the coding and billing guidelines. But most often for drugs that are being billed, you're going to enter this information in item 19 or the electronic equivalent. Claim must be submitted to United Mine Workers of America. Folks that are retired from mining have their claims processed, their Medicare Part B claims processed by the United Mine Workers of America's Health and Retirement Fund. So that claim needs to go to them, not to WPS. Invalid or missing modifier, 43 rejections. I do want to show you on the WPS website where you can find information on modifiers. Now, Bailey has been offering up and continues to do so on a monthly basis a webinar that really takes you on a walk through our website. There's a lot of great information out there. Sometimes you just don't know where it is or how to find it. So if you're interested in that, check that out and register for a Making the Most of the WPS website webinar. I like to search versus navigate. So you'll often in my webinars see me searching like this. I'm looking for my modifier information. I know how to get there, how to navigate to it, but I like to show using search. Now I could have navigated only, but I wanted to show you by using the search, you'll bring up some of, if you use it more than once, you're going to show up some of those results that may have come up previously that you might have used. Here I'm going to choose modifiers, and it is here on this modifier webpage that we have links to our modifier fact sheets, everything you want to know about that particular modifier. One that I like to show and tell about is the modifier 25 fact sheet, because that is one of the most often misused modifiers or incorrectly used modifiers for WPS claims. All of our modifier fact sheets have a definition on them. We have appropriate use on them. We have inappropriate use on them. Some of them, but not all, will include the procedure codes for which that modifier can be appended to. And in this case, for modifier 25, we have included this. The following statements are false, okay? So helpful information, tips are included sometimes, but we always include that definition, appropriate use, and inappropriate use. So that's our modifier fact sheets. Invalid or missing modifier, we had 43. The next one is the IDE number is missing. It should be from claim, not form claim. If you need information about placing that IDE number, the investigative device exemption code, you can look at a resource that we have on our website that talks about the investigational device exemptions. I find that one hard to say. And get information about the IDE submissions and what you need to include on your claim. So I've included that as one of your resources later on in this presentation. And finally, the last of the most common rejected reasons that I'm showing, there are more of course, I'm showing you the most common reasons. The place of service conflicts with the procedure code. Some procedures can only be performed in certain places of service. For example, you wouldn't expect open heart surgery to be performed in an office, correct? Right? I think you would agree with me. So there are edits built into the claims processing system, which is called a multi-carrier system, that won't allow that CPT code for open heart surgery when it's being billed in place of service 11, which is office. So just an example of those edits that are built into our system. So I've included that place of service code list out in the resources that are available at the end of the presentation. I told you that I was going to reveal the most common reasons for rejections. I thought it would also be of interest to my audiences, to those of you that are participating today, to take a look at those codes that are most often rejecting. Pulling something open here on my, here we go. All right, the number one code that was rejected for Part B Specialty 44 claims at WPS during that 3-month time period, remember I used that data dashboard, was the 99232, which of course is subsequent hospital inpatient or observation care, moderate medical decision making, so on and so forth. And these were the reasons. These are all reasons that I've already talked about. 99233 was the next most common rejected code for your specialty, and that's the subsequent hospital care with the medical decision making high. We have already gone over those reasons why that code would reject. 99223 is the initial hospital care, high level medical decision making. Here are the reasons. All of these are those that we've talked about already. The G0545 has similarities to G2211, that complexity add-on code, but this is a code that was created and it is restricted as to who can use this. Only providers that are providing a visit with the complexity inherent to a hospital inpatient or observation code that is associated with a confirmed or suspected infectious disease can bill this code. So it would be your specialty that would be billing this code. You can see the reasons why we rejected the G0545, which is that code used by physicians with specialized training in infectious disease. Nothing new here. These are the reasons why we reject it. Talked about those already. 99222 is initial hospital care with moderate medical decision making. Nothing new there. The 99214 is officer outpatient care with moderate medical decision making, 30 to 39 minutes. These are all reasons that we talked about already. And a couple, well, no more. That is it for the codes that I pulled for you. Those were the most commonly rejected codes. I wanted to show you an example of trending. I mentioned to you that we use the dashboard to look at trending. So by pulling open a particular report on that dashboard, we can look at the trending for a particular specialty or state or county. But for this one, I show that the reason is rendering physician number invalid or missing. And that report or that dashboard shows that during the current 3 months, we rejected 427 claims. In the prior 3 months, we rejected 213, making that a difference of 214. That's a 100% increase in this reason for rejections within those time periods. The current 3 months as compared to the prior 3 months. I mentioned to you that we look at trending. We look at this data to determine our education needs. So why am I talking about all of these today? Because I determined there was a need. These were the most common reasons for rejections and denials. And this trending example shows you that this increased 100% over 3 months. Okay. So, should we hold a webinar? Should we write a resource, an article? Should we consider, posting a YouTube video? All things that we can consider doing in order to provide that education. Next, we're moving from rejections to denials. And remember, these are very, very different things. A denial is actually adjudicated. The potential actions to choose for a denial are different than a rejection. But the number one reason why we denied infectious disease Part B claims during the time period I looked at was this one, which is one of those cryptic reasons, I believe, collection of fee-for-service during periods of managed care. I went to our systems staff and says, does this really mean what I think it means? And they said, yes, Mary, it does. What this means is that beneficiary is one who has elected Medicare Advantage. It is a Part C provider or a Part C beneficiary. Claims for Part C or those beneficiaries who have elected a Medicare Advantage plan instead of Part A, B, traditional Medicare or original Medicare that we process, those claims need to be processed by the plan, not by us. They shouldn't come to us. Look at the next couple and the last bullet. Duplicate charge paid on such and such a day on claim so-and-so. It would have the internal control number there, 843. Next line. This is a duplicate charge, 565. Last line. Duplicate charge of claim, and it will have the control number of the claim, now being processed, 284. That is a lot of claims. This is the second, third, and fifth most common reason we are denying claims for your specialty. They're duplicates. When you receive the remittance advice, or your billing service does, the staff that takes a look at that remittance advice, they need to be doing due diligence or determining the status of a claim before resubmitting another claim. Don't just submit on a cycle. If you use a billing service that bills every 30 days without checking the status of the claim, tell them to stop. It is considered abusive. And if you receive education on duplicate claims and you continue that, an abusive action can also become fraudulent. So we're trying everything we can to reduce the number of duplicate claims. We actually have a great resource out on our website that talks about duplicate claims, and I'll show you where that is in a little bit here. But this one has just been something, as I like to say, kicking us in the pants for all the years that I've worked in Medicare, and I've worked in Medicare more than 4 decades. It doesn't go away, but we still try to educate to bring those numbers down. Why? It costs you, the provider, money to resubmit these charges or to submit duplicate charges, and it costs Medicare money to process those. If you put a dollar amount with each one of those duplicate denials, think of all the money you could save if you don't submit a duplicate claim, or we don't process a duplicate claim. So something to think about. The next one deals with the fourth most common reason for denials for Part B Specialty 44 claims is that the expenses incurred prior to coverage. There was no coverage on that date, 501. That's an eligibility issue. You're going to want to check eligibility. Similarly, the next two deal with Medicare secondary payer situations. Sixth most common reason for denial, that claim must be submitted to the Employer Group Health Plan, or EGHP, or LGHP, which is Large Group Health Plan, first. That means Medicare is secondary. Again, this is something that you would want to be determining for all of your patients. Is there insurance that's primary to Medicare? If so, you need to put that on the claim. Sometimes the claims will edit or they will deny actually because of eligibility issues if there's another insurance primary to Medicare. It does need to go to that other insurance first. The EGHP, LGHP were just a couple of the types of other insurance plans for which Medicare or to which Medicare is secondary that actually denied for your specialty. Expenses incurred after coverage terminated. No more coverage, 344. So maybe the beneficiary doesn't have coverage anymore for whatever reason. This would be an eligibility type of issue you'd want to look up. Provider not eligible or certified for this procedure for this service date. There's a lot of information built into those provider enrollment files. A lot of information you're asked to report when you enroll with Part B. And this would mean that that particular provider, based on the information in the provider enrollment file, is not eligible for this procedure on this service date, or is not certified for the particular procedure on this service date. So, things to consider is your state scope of practice. Is that provider eligible to render that service? Is that provider certified if there's a certification requirement? So this would be a provider enrollment issue that you'd want to look into. Denied service or units of service are exceeded. That, folks, 211 denials means that you billed in excess of the medically unlikely units threshold. There are MUE edits, part of the National Correct Coding Initiative out on CMS's website. You can see those medically unlikely edits in tables. Well, actually, they're edits that identify the claim and then the maximum number of units that you can bill on one day. If you bill more than that, the services in excess are going to deny by Medicare. You can appeal and maybe Medicare will pay for some additional units, but this is an MUE related denial. You may need to consider requesting an appeal. Send us your documentation. Tell us why those units of service exceeded the MUE. And again, not all MUEs are published. Some of them are confidential. So we understand that there's going to be some of these situations where the claims are to be denied, but we just want to provide that education that those units are out there. Sometimes there's a modifier you may be able to use that will tell us why the services are being used in excess or why it exceeds the MUE, but just some things to think about. Look at those medically unlikely edits out on CMS's website. So here then are the CPT codes most commonly denied for your specialty: 99232, 99233. That was number 1 code and number 2 code that we deny for your specialty, and they're all denying for the same reason, both of these codes. Fee for service during periods of managed care, duplicate, and expenses incurred prior to coverage. Let's look at some more. The G0545, collection of fee-for-service during managed care, duplicate, and the provider is not eligible or certified for this procedure for this service date. That code came along, I believe, at the beginning of 2025. I'm not certain. I would need to check it. But, maybe this was a service where we received that claim within that 3-month period, but maybe the date of service was prior to when that code was eligible. Some things to look at, or that the provider was not eligible as certified for that code. Maybe it wasn't well, it had to be a specialty 44 claim because that's all I pulled on the data, but maybe the provider wasn't eligible. That would be a provider enrollment issue that you need to look at. 99223 would be that initial hospital care high level, duplicate, expenses incurred prior to coverage, and then of course collection of fee for service. Provider or the beneficiary elected Medicare Advantage over traditional or original Medicare. Other codes: 99222, talked about that one earlier. The 214, which is an officer outpatient care, moderate medical decision making, all reasons we've talked about already. And then the G2211, which is a Medicare add-on code for evaluation and management services. This was introduced back in 2024 to capture the complexity and the resources that are required for establishing and maintaining that continuous or longitudinal relationship with the patient. Being denied because this service is not payable with other services rendered on the same date. Could be that that code was submitted along with a code other than an E&M code. That is an E&M add-on code. There's a couple other codes that just recently are beginning in 2025. You can also bill with it, but they are a form of an E&M service. Duplicate. Procedure must be billed with primary service. This is an add-on code. So if you bill this code without the primary service, which has to be an evaluation and management service, and a couple more that they've just added on, some I believe the AWV or the IPPE, one of those. It's a form of E&M. You need to bill it with that other primary service. If you don't, we're going to deny it. Collection of fee for service during managed care, the last reason for that. And here's a trending example for denials. The time limit for filing your claim has expired. This is one of those exceptions, folks, that I talked about earlier where you do not have an appeal right. Current 3-month period, we denied 173. Prior to that, we denied 197. The difference is minus 24. So it was a 12% decrease. So this is what we like to see. We like to see those denials decreasing. I want to show you some information and talk about some of the efforts we've made to provide education about timely filing. This is that IDE article that I showed you later. I want to jump back real quickly to the home page. I don't know if you recognize or realize you can do this, but you can go to the WPS logo at the top of any page and click on it, and it will take you right back to our home page. So a nice way to move around quickly. I am going to search timely filing, and I wanted to bring it back to this page to show you what happens because I open this article so often. It's right here at the top of the list. All I keyed was timely, and here is that resource. This is included in the resources at the end of your packet. I want to talk about timely filing because we have been making efforts to decrease the number of denials, which shows on that data that I pulled for your specialty for this webinar. This talks about timely filing of claims. You have 1 year from the date of service. This says that timely filing denials have no appeal rights. You can't appeal it. However, if you believe you have a good cause reason that we should reopen that claim so we can extend that timely filing, this tells you how you can do it. I'm on the J8 Part B website now, so you see Indiana, Michigan. How do I know that? I look at this ribbon at the top of the page and it shows that I'm on J8 Part B. If I want J5 MAC Part B, I just click there and it changes to J5. Iowa, Kansas, Missouri, Nebraska. Some of you might submit claims in both of those jurisdictions. All right, what I want to also point out here is that this particular article talks about when the denied claim is not filed due to a third-party error. We have this happen a lot where providers ask us to reopen a claim for timely filing because another insurance recouped their previous payment, so you didn't submit that claim to Medicare timely. This speaks to that particular issue. CMS does not accept errors caused by incorrect third-party payment as justification to reopen a claim. So we have included that information here because we're trying to lower the number of timely filing denials, and we're also trying to educate providers to let them know that you can't appeal this and we can't pay you. So does that mean you want to submit that waiver if that's the reason why you didn't submit a claim timely? No, you wouldn't. It will not do any good because in this section of the Internet Only Manual, CMS says, no, you cannot pay for this. They tell the max, and we do recognize it's unfortunate sometimes when another insurance that you have, you asked is another insurance primary, you submit to them, they pay, so you don't submit a claim to Medicare. We can't, unfortunately, open them. And sometimes when that company comes back and takes money from you and you can't turn around and submit a claim to Medicare, you have to take that loss. And we recognize that. And it's just a very unfortunate situation. But CMS says, no, you can't make payment. So WPS cannot make payment on that. All right. Here are the fixes for these, and some of these are really talked about, so I'm going to go through this pretty quick. Modifier issue fixes. Make sure that if a modifier is required for an item or service, that it's there on the claim. Make certain that that modifier is one you can use with the procedure code you're reporting, and also make sure that that modifier was valid on the date of service you billed it. CMS adds new modifiers here and there, or new modifiers are added rather. You know, maybe it wasn't a valid modifier in the date of service. Things to think about. Eligibility fixes, fix it, resubmit it. Patient name and MBI needs to be an exact match. If the middle initial's there on the card, put it on the claim. Make certain you're submitting claims to the correct payer. We talked about Railroad Board during this webinar. We talked about United Mine Workers of America, those retired coal miners. Medicare Advantage plans, Part C, you need to submit the claim to the correct contractor. Provider number fixes, you know, make certain you're keying these correctly, make certain you're putting this on the claim, that your enrollment records are valid and up to date, make certain you're associating a billing provider with a rendering provider, and that ordering provider information is entered correctly on a claim. Here's some information about avoiding duplicate denials. Don't auto resubmit. I talked about this earlier. Don't just automatically submit every 30 days. Make certain that you're checking the status of the claim to determine whether or not you need to take action. Make sure you're billing these appropriately. And sometimes there's modifiers you can use to tell us, yes, this indeed was a repeat procedure on the same day by the same provider, or a repeat procedure on the same day by a different provider. Here is some information I've included that speaks to Medicare's secondary payer situations. There's a fact sheet, the questionnaire that you use. Send these to your patients to determine whether or not someone else may be primary. And I mentioned to you, we have on our YouTube channel some great videos that speak to Medicare Advantage, also to Medicare secondary payer eligibility. We actually have a Medicare secondary payer playlist out on our YouTube channel. I'm going to click on that real quick and see how long it takes to open. Not too long, it's coming over. And you can see that on our MSP playlist, we have 14 videos currently. So some good information to know about. CMS also has an MSP webpage. More resources and tools. This is where I'm going to go pretty quickly because you can come back to this later. I've embedded links to claims processing manual instructions, the paper claim form, Part A, Part B. I've also included this general EDI and EDI support requirements. We have the IVR that you can find claim status and details on. This is where you use your voice or telephone keypad. We have an operating guide that tells you how to use this self-service tool. Another self-service tool is Snap. Oh, I'm sorry, scrolled there when I shouldn't have. SecureNet Access Portal, I showed you where you can find the portal user manual, links to it. This can be used to check eligibility. You know, check claim status, claim details, and claim actions. If we deny a claim, it's going to give you more help when you're looking at the details of that particular claim line if you're using our Snap tool, and it'll actually provide you with links. So for example, if we denied a claim line due to a policy, you can click on a More Info button on Snap and it will take you right to that policy. So some really great time savers. We have for both rejections and on the next slide, denials, website resources. I talked about those reason and remark codes earlier, you know, MA130 and, you know, the group codes that I talked about. But take a look at your remittance advice. Look at the reason and remark code. If your claim rejected, come out to this article or this resource on our website, find that reason and remark code, and it will tell you how to fix it. Similarly, it does the same thing in this resource on our website, Common Claim Denials. Look at the reason and remark code. Come out here. These we've kind of put into categories so you can look under bundling. Find your reason and remark code. See what you need to do. Provider number details. Look at that reason and remark code. Come here. It tells you what to do. Okay. Website resource. Here's information on how to request a clerical error reopening, and I am opening that up really quick here because this tells you those corrections that can be processed as a clerical error reopen and those that can't. A lot of providers ask me about that, so I like to show you. It's in that article. The place of service list is there, modifier web page. I showed you that earlier. Live events are coming, webinars. On October 16th, we are hosting our second Medicare Education Expo. We're going to have a little fun with this, folks. It's kind of a Halloween theme. our whole team had fun putting together the descriptions of these. These are 5 separate events happening on the same day. It's really kind of a series. All of the education's related to the life of a claim, or what happens to a claim when it comes in and as it moves through systems. I'm doing a presentation on that day about post-payment review of claims. So take a look at that advertisement. I believe Bailey's placed some information into the chat about that event. It's called Mediscare Madness. We have Encore Presentations webpage. Here's that article that I promised you I had here about those investigational device exemption submissions, timely filing, place of service, more YouTube. We have a lot of information on YouTube. Our Medicare EDI webpage is a separate website for all things EDI. It has those companion guides, how to read those reports that come to you to let you know if your claim came in the door or not, those pre-pass edits, that 277, 276 companion document. There's also a link on that page to the crosswalk, and I do like to show this because a lot of people don't know about this, so I'm pulling it open and bringing it over so you can see it. Oh, wrong window, Mary. Hang on here. There we go. This is our crosswalk, and what this does is it crosswalks. If you put it here on a paper claim, what do you need to put on the electronic claim and where? So we have by item on the claim. You can see 1, 2, 3, so on and so forth, all the way up to the final item on a claim form. Here, oh, I'm still going, 33B. Okay. If it goes in item 29 on the paper claim form, where do you put it on the paper or on the electronic claim? It's right there. Is it required or is it situational? That's what this status column is. If there's an R here, that means you put something in that spot on the claim. If it's situational, it means it's a data element that must be completed if other conditions exist. Also gives you the requirements for the version 5010, the current electronic claim form. What is it you're putting in there? What are the requirements? And the data element description too, patient paid amount, for example, patient control number, lab or facility name, so on and so forth. So that is the crosswalk. It's a really handy guide to how to. Next is CMS resources. This is a fact sheet about checking eligibility. This is a review contractor directory interactive map, and I pulled it open. It's coming over on my other page. It's a map, and for some reason the map's not showing, but you can click and find for any state information on the various contractors and such, and the contact information. So that is good at knowing where to send the claim. We have the relative value files out on CMS's website. There's a status code column that tells you whether that code is active or not. It tells you whether it's bundled. There's ordering and referring files on CMS website, a compilation of all the providers who can order and refer Medicare services. It also has all of those providers NPI, and it is searchable. Here's links to those National Correct Coding Initiative edits, which has a part of those edits are the medically unlikely edits. This is for those denials when the MUEs exceeded that MUE that's published by CMS, or not published by CMS, but in place when claims are processed. IDE studies information here in the IOM tells you to report that clinical trial number on the claim. If it's missing, your claim is going to reject or denial. And here, folks, is where I would normally ask Bailey to read off any questions that were received in chat, but I am showing 11 o'clock, so I'm going to wrap this up, but I'll tell you how you can send questions if you've not already placed them into the chat. We are excited to make changes based on your feedback. Your comments are so valuable to us. We read them, CMS reads them, every single one of them. Recently on surveys, you have suggested to us to find a way that you can look at one of our videos and not have to start at 0 minutes and go to 60 minutes. You want to just look at something in the middle. Well, if we take, for example, the agenda and we convert it to chapters, or think of it as a table of contents, you can move around. So for example, if you come back to a YouTube video and you don't want to hear all of that information I said at the beginning, but you do want to look back at those lists of rejections and denials. You can do that by going to that chapter. Click on it and move through that. You don't have to listen to the entire recording of the video. We've also added training indicators to the announcements or the descriptions of our events, so you know, is that event one designed for you? So for example, are you new to Medicare with less than 6 months experience? We have a training indicator, which is NTM. If you see that, that means it's new to Medicare, for designed for new to Medicare, clinical, billing and coding, so on and so forth. Here's something very important, because I know a lot of you are seeking continuing education units. We do not give CEUs out, but we do give you a certificate of achievement you can turn into an accrediting body to request that they give you CEUs. Following today's event, I want you to listen carefully, because we get a lot of emails after events about this. You are going to receive an automated thank you for attending email. It might have already came out, because I'm showing it's 11:01 and it's set to go out at 11. It's going to thank you for attending, but that email goes out to you only if you actually watched the presentation today. If you dialed in only, you're going to get an email, but it's going to say, sorry, we missed you, because WebEx doesn't know you weren't there when all they have is your telephone number. Okay, so if you did not dial in and listen only by telephone, if you're actually seeing the slideshow that I'm showing now, you're going to get that follow-up email, not from WPS, but from WebEx. In the body of the email, it's going to say certificate, and just below it is that verbiage that will serve as your certificate of achievement to turn into that accrediting body. We'll have the name of today's program, 1 hour, and so on and so forth. Remember, if you joined only by phone, you're not going to get that automated email with the certificate, but you're going to get one that says, sorry, we missed you. And then what you'll need to do is send an email to WPS, our education mailbox. The email's here at the bottom and also on this slide. And tell us, you know, you joined only by phone. Here's my phone number so that we can confirm your participation, and we will send you a manual certificate of achievement. Don't look for an email from WPS. These emails come from WebEx. Can't find it? Check your spam or your junk folder. Many of you work for a company that automatically delivers those types of emails to junk or to spam folders. So take a look at that. If you have troubles, just let us know and we'll help you out. You can send follow-up questions. If you think of something between now and a week from today, send it to the education mailbox shown here, wps.gha.education@wpsic.com. Place today's topic in the subject line and I will send you an answer. 7 days, and it has to relate to what we talked about today. Any non-presentation related or claim specific questions do need to go to customer service. I talked about how important that survey is. Let us know about this customer experience today. If you're not willing to give me a 5, you need to tell me why. 5 being the highest, and we certainly hope we did give you a great customer experience survey today. If you have suggestions for future topics, let us know. This is where we get a lot of our ideas. My entire team looks to those surveys. We look at every single one. CMS looks at every single one. We want to know what we can do to make you happy and give us all 5s. If you have not yet done so, when you leave today's webinar, you're going to get a pop-up that's going to look like this white box at the bottom and middle of your screen with a yellow triangle at the top. It's not a malicious thing at all. What it is one last reminder that we would love for you to take that survey and give you feedback. It's CMS's Qualtrics website. If you have already taken the survey, you can X out of it. But otherwise, it's a great opportunity right then and there to do it while everything's fresh in your memory. Please take the survey. That concludes today's presentation. I do want to thank you for taking time out of your busy days to participate in this webinar. On behalf of myself and Bailey and all of Provider Outreach and Education, I do want to thank you for your participation. We look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everyone. Have a great day and a great week.